Good morning. Good morning, Tanisha. Thank you. That's a great idea. People can write in their names if you like to write where you're coming from and your name and which country you're joining us from. Welcome. Welcome, Annalisa. Good morning. Good morning, everyone. All right. I think I just want to give people 1 minute and we get started. Good morning to our panelists. Thank you for joining us so promptly. Excellent. Good morning. Wonderful. Oh, good morning. Good morning to our colleagues joining us from Trinidad and Tobago, Guyana, Jamaica, St. Kitts and Nevis. Wonderful. Thank you so much. Okay, well, with let's get started. Good morning, everybody, and welcome to the Caribbean Public Health Law Forum Capacity Building webinar. The Caribbean Public Health Law Forum is the space that has been created to bring people from different fields, such as law, public health, non-communicable diseases, and other areas that may have affinity to the topics that we'd like to share with you. Throughout, since its inception in the last few years, it brings different topics such as tobacco control, nutrition policy, and today we are looking at the topic of health taxes. Why are we looking at this topic? Well, a recent article authored by Sir George Allen, by Dr. Chris Tufton, as well as Awa Mari Cole and Dr. Thomas Frieden, have make reference to what are some of the most effective best buys, as WHO has coined the term, or cost-effective interventions. And one of them is to implement and increase health taxes. And we will hear today from a wonderful panel on what's the rationale? Why are we bringing up the topic of health taxes that may be a difficult conversation? It may be a different conversation. So we have titled our webinar, Conversations on Tax Policy Design, Implementation, and there is a very special angle that we have a very special presentation as its relationship to accessibility to healthy foods in the Caribbean. So I'll be introducing our speakers one by one, and they will go ahead and do the presentation, and we'll leave questions for the end of the panel's presentations. So let's start with our colleague from PAHO, our economist, Itziar Belawistogigoitia, and it's a very hard last name to pronounce. Itziar, it's an economist, and it's part of the team dedicated to the economics of NCDs. So please, Itziar, with your presentation on health tax resource modeling and monitoring, and an overview of the status in the Caribbean and in the Americas. Thank you, Itziar, for accompanying us. Please go ahead.
Thank you, Gloria. It's very nice to be here with you all. Let me go back because there we go. Thank you for inviting me to talk about health taxes. It's a subject that I'm quite passionate about, so I'm very happy to be here with you all. I'm going to go very briefly through the motivation of why I use health taxes, a brief overview of the status and progress in the Caribbean, and also share with you some tools and resources that are available to you all to advance with this important policy tool if you are interested. So first of all, let's talk about why health taxes matter. Gloria mentioned NCDs and why they're a problem. Globally, we know that 43 million people die from preventable non-communicable diseases, NCDs. This includes heart disease, diabetes, cancer, etc. And concerningly, we know that 82% that 82% of I'm sorry, that 18 million people die prematurely. This means before the age of 70. Oftentimes when they're the most productive in their lives. So this is quite concerning also in terms of development and growth. Of these 18 million deaths, we know that 82% occur in low and middle income countries, which again is increasingly concerning because these deaths occur at the prime productive years of many of these individuals. Some of the major culprits behind these deaths are modifiable behavioral risk factors, which include tobacco, alcohol consumption, and unhealthy diets. These three elements are major drivers of this burden of death and disease. It's important to note that most of these deaths are preventable. So let's look at how some of the trends have evolved. Overall, we do see that the health cost of tobacco, alcohol, and sugar-sweetened beverages, which are part of unhealthy diets, are rising globally. The deaths are increasing in particular due to tobacco and alcohol are particularly increasing in low and middle income countries. While the SSB, sugar sweetened beverage related health burdens are rising in both low and middle income countries and high income countries, although the growth is faster in low and middle income countries. In the Caribbean specifically, tobacco, alcohol, and sugar-sweetened beverage-related deaths and disease are rising. So this is of particular concern to the Caribbean sub-region. And while tobacco remains the product with the largest associated health burden, alcohol-related harm is rising faster, and the health impact of sugar-sweetened beverages is also rising rapidly. What do we do about all this burden? As Gloria mentioned, we do have a set of a menu of policy options that are cost effective that have been evaluated and have been deemed feasible for implementation in most contexts. We have the Global Action Plan for Prevention and Control of Non-Communicable Diseases, the first image that you see here. And to accompany this roadmap of effective policy options, there is the document that Gloria mentioned that evaluates the cost effectiveness of different policy options. This document has been updated twice since the inception of the Global Action Plan. The most recent update was made in 2023. And basically what this seeks to do is evaluate the cost effectiveness of different prevention and control policy options. The most effective options are deemed best buys, and as part of these, we have tobacco excise taxes on tobacco products and alcohol products. And as a good buy, we have the taxation of sugar-sweetened beverages. We often get asked why it's not a best buy, and it's not that it's least effective. The reason why it's in a different category at this point is because of modeling constraints. But the evidence that we do have available to date is very encouraging, and it indicates that that sugar-sweetened beverage taxes are in fact very effective in also reducing NCD, in reducing consumption and associated NCDs. So maybe let me take a step back and perhaps answer your question on what exactly are health taxes. So it's a tool that we have for reducing consumption of health-harming products. These are applied to products that cause harm to health and have negative externalities and internalities. Historically, they had been called sin taxes in some countries. However, the current trend is to label them as health taxes to underscore their positive impact on health. We're aiming to improve health. We're not aiming to penalize behavior that we deem undesirable. We want to put that positive spin to underscore the positive effect it has not only in health, but you'll see on other aspects as well. The most common types of health taxes are on tobacco, alcohol, and sugar-sweetened beverages. I've already mentioned this some throughout the presentation. And what they do is they help us correct market failures by internalizing cost. Essentially, they raise the price of the relative price of unhealthy products. However, they're not only a tool that helps us improve health. They, of course, help us save lives by reducing the consumption of harmful products that are associated with NCDs. But they also help us mobilize additional government revenue that can be used for different development priorities. In addition, there's also ample evidence in the context where they have been implemented that they help reduce inequalities. It's often the most vulnerable populations that are the disproportionately benefited from the implementation of health taxes. So they're the groups that diminish their consumption of harmful products the most when faced with a tax increase. And consequently, they're the ones that see the most benefit in terms of health returns and productivity. Another benefit of health taxes is that they reduce the associated diseases in the long term. So what we see is that they have a positive effect on the health system, on the financial viability of health systems, as they free up resources to avoid NCD treatment. We know that NCD treatment is costly and frequent. It's quite different than treatment associated with communicable diseases. And we also know that a lot of countries aren't ready to face the upcoming burden of NCD. So it's really important to consider these additional elements. And what you see here is the pathway through which health taxes accomplish this. As health taxes increase or are improved in their design, the price increases, the affordability of health-harming products decreases, consequently their consumption decreases, and associated death and disease decrease. As we have the associated NCD deaths and disease decrease, we see other co-benefits as decreased health expenditures, a healthier population, more productive population, and increased revenues. So now, where do we currently stand? So for tobacco, we've been measuring progress since 2008. We have very well-developed tools and resources to track a country's development in this policy area in particular. One of the elements that we use to monitor progress is tax share. So basically, what is the component of the final retail price that corresponds to taxes? This is one of our main indicators used in tobacco taxes. And for cigarettes, the WHO recommended threshold of a minimum tax is 75%. So per WHO recommendations, at least 75% of the total price of each cigarette should correspond to taxes. In the Caribbean subregion, what we've seen is that the progress has remained relatively stagnant since 2008 in regards to this indicator, and is significantly below the 75% threshold set by WHO. The average tax share in the Caribbean is currently around 34%. Another element that we use to assess progress is affordability. What is the impact of different tax policies, etc., on making these products less affordable? That is our ultimate goal, to make these products less affordable so that people consume these harmful products less. So as I mentioned, for tobacco taxes, we've been measuring different elements since 2008, so we can evaluate changes in affordability. what we see overall in the region is a small but negative trend. In 9 out of the 33 countries, cigarettes have become more affordable, so that's contrary to our goal. Unfortunately, out of these 9 countries, 3 are in the Caribbean. This include Guyana, Grenada, and Belize. Um, and in addition to affordability, I understand Miriam will talk more about this. It's important to consider different design elements. Each design decision is going to have different incentives and disincentives, which are very important to consider. So we also track, in addition um, to, to tax share and affordability, different design elements, which include the type of tax and she will go more into detail about this. But in short, we have 10 out of 14 Caribbean countries that apply specific excise taxes. This is good. This is aligned with best practices. However, none of them apply an automatic adjustment. This is bad because this means that these taxes, unless specific action is taken every year, will be eroded over time. And we see this in some of the trends when we look at increases in price and increases in taxes. We see overall in the Caribbean that increases in prices are driven by industry profits. So we do see that prices are increasing. In a lot of countries, we see that affordability is consequently decreasing, but we do see that this affordability decreases are due mostly to industry profits and not to the health tax policy driving the decreases in affordability. So in short, what we see here is an opportunity. We see an opportunity to make better use of tobacco taxes to decrease the affordability and to mobilize more revenue. Now let's move on to alcohol taxes. We do not have as much history of tracking progress, so I'm going to give you a snapshot of 2022, which is the latest that we have available. We have a similar story in alcohol taxes. They're often low, and there is space to improve the policy design, which Miriam will go into a bit further. In the region, it is concerning that we have the second cheapest alcohol amongst all regions, and some of us the smallest tax shares. Overall, we do see that levels across the Caribbean are lower than in Latin America. So even within our region, we see that there is space for the Caribbean to improve on this health tax policy. And we do see also space to improve on the design, where most countries for alcohol taxes don't apply a tax based on alcohol content. And we see that even within countries, the tax share varies quite significantly across different beverages. So overall, the message is similar. There is ample space for improving the tax structure and the design of alcohol taxes in order to really leverage the public health impacts that these have. Next, let me move on to sugar-sweetened beverage taxes. Here, I think it's very important to note that the Caribbean and Central America have astoundingly high rates of sugar-sweetened beverage consumption, over 3 times the global average. This is very concerning. We know that sugar-sweetened beverages are a high proportion of free sugar intake in many of these countries, and that this has very many negative health impacts. I won't go into that, but the manual has a lot of information about why, for example, consumption of sugar-sweetened beverages is particularly concerning from a health perspective. Overall, in the region, we see that 22 out of the 33 countries already apply some sort of sugar-sweetened beverage tax. In the Caribbean, it's 6 out of 14 countries. And this was a relatively new finding. It was thought that most countries did not have this policy instrument implemented, but after doing a review of legislation in 2019, we found that actually most countries in Latin America and the Caribbean already do have some sort of tax. The issue with most taxes is that these are not designed from a public health perspective. Miriam, again, I hope we'll go more into details about the importance of design, but it's very important to take these designs into consideration because, again, they create incentives that are either positive or negative. What we see overall in Latin America and the Caribbean is that in the countries where an SSB tax is applied, the tax doesn't apply to all beverage categories that it should in theory apply to. WHO defines sugar sweetened beverages as any beverages with free sugars, and this includes sweetened milk and juices. Most countries exclude sweetened milk and juices. These are metabolized in the same manner as soda. So from a public health perspective, it doesn't make sense to make any exceptions for these. You have the same health effects. Another gap and opportunity for improvement that we see is that a lot of countries apply the same tax or even a higher tax to bottled water. Bottled water is healthier alternative to sugar sweetened beverages, and in theory, it should be taxed at a lower rate in order to incentivize its consumption. In terms of the burden, we usually see that the tax share is pretty low. So the takeaway here again is similar. Sugar sweetened beverages in the region and in the sub-region are largely not designed from a public health perspective, and there's space for improvement in this structure and space to increase the rates. My overall message is for the status of health taxes in Latin America and also the Caribbean. They're largely underutilized tools, despite being very cost-effective measures to reduce consumption and prevent NCDs. For tobacco overall, we see that countries haven't made much progress since we started monitoring in 2008. And alcoholic beverages, we see that the design is not based on a public health rationale. For sugar sweetened beverages, it's a similar conclusion. We see that they're not being applied to all beverages that they should be applied to, that the taxes are relatively low and ample room for improvement. Overall, unfortunately, we do see that the Caribbean is lagging, but this is also an opportunity to catalyze action. I'll end with some tools and resources. We have WHO manuals that address each one of these products. And we also have PAHO and WHO reports that can help you identify where your country is in each of these different health taxes. And I'll leave you with that. I'm sorry, I know I ran a bit over time, but here is my email in case you have any questions. Thank you.
Wonderful. Thank you. Thank you, Itziar. I mean, you really set up the stage for our conversation. And our speakers are high caliber. I don't want to take much time. I would like to go now into the introduction of our next speaker. We're trying to cover a lot of ground today because it's so important. Please, let's welcome Dr. Miriam Alvarado, who is the Wellcome Trust Fellow with a joint placement at the MRC Epidemiology Unit at the University of Cambridge and the George Allen Chronic Disease Research Center here in Barbados. You are in for another wonderful presentation, and please save your questions towards the end. Please, Miriam, and welcome.
Thank you so much, Gloria, and thank you so much for having me. Can I just confirm that you can see these slides okay?
Yes.
Okay, perfect. This is great. Thank you, Itziar. I'll be building a lot on the concepts that were just introduced in the prior presentation. So I'll speak briefly on health taxes in the region and then really focus in on some critical considerations around policy design. And I'll hopefully aim to bring these to life through zooming in on one specific case study looking at the issue of health tax policy design as it's applied to sugar-sweetened beverage taxation in the case of Barbados. Then I'll zoom back out and share a few reflections on monitoring and data needs for the future of evaluation of health taxes. So to take a high-level perspective and just to echo the kind of key message we heard earlier, this is a summary of NCD progress indicators across the world, and you can see that we pulled out the Caribbean in this first column. So these numbers correspond to the proportion of countries that have fully or partially met these indicators. And you can see that we have on tobacco taxation, kind of the lowest overall regional performance compared to other areas in the world. And when it comes to alcohol taxation at 54%, still a lot of room for improvement. SSB taxes aren't included here. But actually, before I get onto them, I'll disaggregate this by country. So you can see that actually there's very few countries that have made even partial progress on achieving the tobacco taxation sort of best practice recommendations. So there is a lot of opportunity here. And also when it comes to alcohol taxation, we heard a little bit about how one of the best practice designs can be tying taxation to the cause of health harm. In the case of alcohol, liters of pure alcohol. So we do see that type of design being applied in Jamaica. And there are ways that even the alcohol tax in Jamaica could be further strengthened. But that is at least one example that demonstrates that type of structure in practice in the subregion. But again, and I'll touch on this towards the end of my presentation, there are some very concrete and practical ways that alcohol taxation in particular could be both simplified and made more effective. Because we don't have SSB taxation in that progress indicator summary, I'll focus in on it a little bit here. As we heard before, sugar-sweetened beverage consumption is really high in the Caribbean relative to elsewhere in the world. Like Itziar said, in some cases, 3 or even more times higher than the global average. And why this is concerning? Well, we have evidence that SSBs impact NCDs in a couple of different ways. So as we probably are all familiar, SSB consumption can lead to increased body weight, increased BMI, and that can have a slew of effects on diabetes, cardiovascular disease, and many other conditions. But the thing about sugary drinks is that they also impact diabetes and cardiovascular disease independently of their weight gain pathway. So they're impacting these conditions in multiple different ways, which is a bit unique and a good reason for targeting them in particular if we're trying to reduce the incidence of new cases of NCDs. We heard a little bit about the tax share as a way of assessing and monitoring countries' performance when it comes to health taxes. This is a snapshot from 2022 of SSB taxation in the Caribbean subregion, and you can see a few countries implementing these taxes, but kind of across the board at relatively low levels. So again, there's space to increase these rates, but also to improve the tax design to make the taxes we have more effective and to introduce them in countries where we don't yet have excise taxes on sugary drinks. I should note that a few countries have engaged in reform around sugar-sweetened beverages since 2022, and I'll come back to that towards the end of the presentation as well. So to focus in on the case study I'm going to look at, we're coming to Barbados, and in 2015, the SSB tax was introduced at a rate of 10%. And I really want to highlight this because that's what I'm going to be focusing on for the next few slides, the type of tax that was introduced and some of the implications of that particular tax design. So there are different types of excise taxes, ad valorem or value-based tax, like what we've seen introduced in Barbados, or specific taxes, which are based on a physical characteristic of the product. So when it comes to sugary drinks, this tends to be either volume, so like a certain amount of money per liter, or sugar, so a rate on grams of sugar. And of course, this varies when it's applied on alcohol or on tobacco. So for SSB taxation, specific tax designs are really preferable and recommended as best practice for a number of reasons. And I'm going to propose these to you and then illustrate what we found in real life. So the theory is that ad valorem taxes can incentivize brand downswitching brand down switching is when consumers respond to a tax-induced price increase by substituting away from the products they were purchasing towards lower cost versions of the same type of product. So there's no change in the health harm. They're just responding to the increased price by optimizing. And ad valorem taxes make this more possible to do because of the types of impact they have on product prices. So we tried to look at this empirically and see whether we found any evidence of brand down switching following the 10% sugar sweetened beverage tax in Barbados. So this slide corresponds to our assessment of change in sales volume of the cheapest sugary drinks up here, the mid-range ones, and the most expensive ones. And what you can see is we really do see this decline in the highest or most expensive sugary drinks following the introduction of the tax in 2015. So that is this darker black line here compared to what we expect would have happened in the absence of the tax. But the story gets more complicated because we actually see an increase in sales of mid-range drinks. Now, the net effect was still a decline in sugary drinks, so the tax was still effective overall, but at least a certain proportion of consumers seem to have responded by engaging in this brand down switching, which we know is associated with this particular type of tax design. Okay. Ad valorem taxes are also thought to favor low-cost drinks and to encourage the introduction, potentially, of more low-cost variants of the health-harming products. So we had kind of accidentally found this in the Barbados case. Again, you can see a range of different sugar-sweetened juice drinks being offered at different price points before the tax was introduced. And then after the tax, there's actually a new product that enters the market at a much lower price point. So even with the tax, it was still more affordable than the other products, although it had similar sugar content, similar health harms. So this is another demonstration of some of the unintended consequences that tax designs can have, and a reason why we are hoping to transition towards more specific taxes in this area. For the next 2 points, I'm going to be speaking about ad valorem taxes applied on what's called the producer price. So let me define that. The thinking is that ad valorem taxes, when they're applied on a producer price, actually lead to lower than expected price changes. So what does this mean? Digging into what it looked like in practice, when an ad valorem tax is applied on a producer price, products that are imported pay this tax on a value earlier in the distribution chain. So they pay the 20% or 10% tax on the cost, insurance, and freight when they bring these products in. And on the locally manufactured side, manufacturers pay the tax. Sorry for the inconsistency here between the 10 and 20%, but they pay the tax on a declared producer price before that product gets, encounters the retailer's markup, which inflates the price that consumers see at the checkout counter. So maybe to illustrate this in a different way, if we now consider the 20% ad valorem tax, which has been most recently implemented in Barbados, we could imagine a producer price here of $1.29. The 20% tax on that would be 26 cents. But then the retailer is able to add their profit, their markup, onto the net cost. We've estimated that to be about 30% typically. And so we end up with a product and the final retail price, which when you compare that to the amount of the tax is actually more like 11, 12% of the price. So although we have a 20% tax, even if it's fully passed through, if no one's absorbing the extra cost of the tax, we still expect to see a lower ultimate change in prices. And that's because of where in the value chain the tax is being applied. So there are other instances where these taxes, ad valorem taxes, are applied on the retail price. And there's challenges and benefits to that. But I just wanted to highlight that although 20% can sound like a relatively big number, when you work out the details of it, we see a lower change in ultimate price. In this example, I've been disregarding VAT. So this is slightly simplified, but I think still useful to get the point across. And finally, it's been thought that if ad valorem taxes are applied on the producer price, they may favor local manufacturers. And while we don't have direct insight to say whether or not this is happening in the region, We know that this means the taxes might be susceptible to undervaluation because they're self-declared producer values. And we do see that in general, products produced by local manufacturers seem to have a competitive advantage in the period after a tax is introduced. So that's another thing to keep in mind, or another consideration with these tax designs. I'll switch gears to another aspect of tax design. This is the definition of products to be taxed. And this is hugely important. The best practice recommendation is to comprehensively capture as many of the health-harming products as possible to minimize the chances of substitution towards untaxed health-harming alternatives. To do this, the guidance is to really assess setting-specific beverage market and consumption patterns. And so this slide has a lot going on. It's a complex slide, and that's partly the point, to show that the sugar-sweetened beverage market has a lot of differentiated products. And this does make it challenging to design a very effective and comprehensive SSB tax. But we're seeing progress in this area as well. So let me walk through what we see in this figure. On the y-axis, we're looking at average per capita consumption per day. So this is based on repeated 24-hour dietary recalls, so quite a valid and rigorous assessment of dietary intake. These were conducted in Barbados in 2012, so a little bit a while ago. But you can see that there are relatively high levels of consumption because this is what the average person consumes in one day. Then on the x-axis, we see the sugar concentration levels of those different products. So you can see a wide distribution of sugar concentration. We haven't talked about this yet in terms of tax design, but there are taxes that are based on tiers, or a sugar-based specific tax more effectively targets the most concentrated sugary drinks, whereas sometimes the volume or value-based drinks don't necessarily differentiate between high and low sugar added drinks. So we'll see some of the implications of that in the next slide. And then finally, all these different colored bands correspond to different types of SSBs. And so in kind of gray here, you can see the one we think of the most, sodas. And that is definitely a big contributor to the pattern of sugar-sweetened beverage consumption. But there are a lot of other products that are coming into play here. So we see in light gray, the sugar-sweetened juice drinks. We see things like Mauby here in kind of turquoise. Energy and sports drinks, things like Gatorade, those type of drinks. Powdered SSBs, here in the kind of magenta purple. So these are actually untaxed, things like Tang and Turbo powders that are used to reconstitute quite sugary drinks. And then we also see things that are actually not sold in a ready-to-drink fashion, but still contribute to people's consumption of beverages, right? So like home-sweetened teas and coffees, or other homemade sugar-sweetened beverages. So there's really a lot going on when we dig into the details of consumption patterns around these beverages. I'll note here that we included 100% juices, although these are typically exempt from SSB taxes, because 100% juices still include free sugars. And so we, can see the sort of health harm linked there, but you can see they're a relatively smaller contributing beverage product. So in the case of the Barbados SSB tax, harmonized tariff codes were used to differentiate taxed products versus untaxed ones. In some cases, especially for the juice drinks, this necessitated actually creating custom codes to distinguish between sugar-sweetened juice drinks and unsweetened juice drinks. And then some of these products are in different chapters. So it also requires kind of quite careful examination of lining up the nutrient profile of products with where they fall in the harmonized tariff schedule. Here, we've summarized the prior slide by taxed and untaxed products. And ideally, we would want the most high sugar products to be taxed. But actually, you can see there were some kind of exceptions here, some loopholes. One of them, like I mentioned earlier, had to do with Mauby syrup, which actually I'm really pleased to say was reformed. So in 2017, the government of Barbados included Mauby syrup in the definition of taxable products, strengthening and kind of closing that loophole in the tax design. I mentioned other countries that have introduced SSB tax reform recently. So Dominica increased their tax on SSBs. They actually implement a specific tax. So going back to that conversation about ad valorem versus specific, this is an example of a specific tax based on volume. And it's quite a substantial increase, equivalent to US 44 cents per liter. But when it comes to the definition of taxable products, there are potentially important places where this tax could really be strengthened. There's a few different sort of taxes applied on different products, and it's not clear whether the tax is applied on sugar-sweetened juice drinks, sugary dairy drinks, as Isira mentioned, and other types of SSBs, which might produce these sort of loopholes and be potential substitutes. We also saw in Grenada the introduction of a differentiated value-added tax. So this is not best practice because of complications related to value-added taxes, but there could be potential to shift towards an excise tax here. But I wanted to flag it because these are two kind of areas of reform that have happened in the last couple of years in the region. And I think they both provide important opportunities for learning. From an evaluation perspective, many countries rely on commercial household purchase data like Nielsen or Kantar panels. And unfortunately, as far as I'm aware, many countries in the Caribbean do not have access to these types of data. So instead, we've had to be a bit creative about the data sources used to evaluate and monitor these taxes. But there are data available at varying levels of detail. So consumer price indices, import data, revenue data, or electronic point of sale data from major retailers can all be used and all have varying strengths and weaknesses. I won't spend too much time on this, but if anyone is interested, I'm very happy to connect and discuss this after the session. There's also been kind of an increased interest, and this is a quotation from the WHO manual on SSB taxation policies. So there's been increased interest in evaluations that acknowledge contextual factors, feedback loops, the possibility of unintended consequences, industry responses, and kind of the interplay of public opinion, social norms, industry response. But what are appropriate methods to produce these types of evaluations? And that's something that my team and I are in the midst of working out. We are working with really lucky to work with this group of stakeholders in Barbados to inform a second evaluation of the 20% Barbados SSB tax. So that work is ongoing and forthcoming, and really involves trying to map out the system around sugar-sweetened beverages and think through some of these potential unintended consequences and contextual factors. Of course, evaluation has been especially challenging in the last few years because it's been such a volatile time, and we've had inflationary pressures around the world in the last few years. But in the Caribbean in particular, the impacts of tourism and of COVID-19 related travel bans and restrictions have really made tourism numbers and the economy fluctuate quite a bit depending on country by country. But that's kind of a crucial background factor to take into consideration in any of these evaluations. And finally, I just encourage, capturing as much as possible industry responses within the scope of evaluations. We've really seen that as an important factor in the Barbados case. I said I'd very briefly come back to alcohol. I think I'm already out of time, but I just wanted to highlight these are the excise rates applied to alcohol in Barbados, but we see a similar pattern in several other countries in the Caribbean as well. I know that's small, but the main point I want to make here, there's actually 2 slides, is that there's huge amount of differentiation about the rates that are applied on different alcohol products. And in this case, at least, they're not tied to the health harm, liters of pure alcohol, but rather based on different categories of alcohol. So rum and whiskey might be taxed completely differently, although from an ABV perspective, they're more comparable in terms of health harm. So this is really an area where the tax policy design strengthening could make a very big difference from a health perspective. I'll just conclude again by reiterating that message that there are a lot of ways to strengthen health taxes and a lot of opportunity here. And I hope that this session provides that call to action and inspiration for continued work in this area. Thank you so much.
Thank you, Miriam. This also has been delightful, in-depth, and we can see, of course, that the design of the tax is paramount, and it brings in so many different types of expertise from economics, nutrition, policy, and probably others. And also, you have been so conscientious in showing us the evaluation approaches. So we really thank you. And in interest of time, because each of these presentations could really be a keynote for any of these topics. So I would like to thank you and move on to our next presenter. This is really wonderful to have this type of conversation, and we hope we're going fast from presentation to presentation, but we hope it's also igniting further interest in these topics. We have with us Daniel Bloom, who is the Senior Coordinator for the Global Tax Program, Health Taxes Project, and the Macroeconomic Trade and Investment Global Practice at the World Bank. And she's going to present for us on health tax revenue use, evidence, policy considerations, and possibly she would also include some country experiences. So thank you so much, Daniel, for accepting our invitation. And please take it away. Thank you.
Excellent. Thank you so much for having me. It's a pleasure to be here. So today I'm going to focus on the topic of health tax revenue use, and I will certainly define that for you all in just a minute. But I want to talk a little bit about earmarking first. We all know about the concept of earmarking. And in the context of health taxes, earmarking comes up a lot. So health taxes, we know, are good revenue generators, especially when we look at tobacco and alcohol. They can generate 0.6 to 0.3% of GDP on average, or they do, and there's still additional potential there as well. Health taxes also, because of their focus on targeting negative internalities and externalities, can also improve population health. And as I mentioned, in the context of health tax reforms, because of this really close link to population health impacts, earmarking comes up a lot. And we hear this a lot in our program. So our program is situated in the macroeconomics, trade, and investment global practice, where all of our country economists sit. They work on a lot of tax interventions and other types of interventions with countries. But we have a lot of understanding that fiscal economists are not into earmarking as a topic, but it really does come up a lot in the context of discussions with our health sector colleagues. And so as a result of that, we wanted to look, as a part of our work, because we do work in health taxes in many countries around the world, on what really countries have been doing around health tax earmarking and how it has worked at the country level. And so we have a knowledge product that will come out hopefully later this year. PAHO has contributed a couple of case studies to this knowledge product, and I'll get into some of the results. But through our work, we started to see this evolution in the terminology from earmarking to this concept of health tax revenue use. And we say revenue use because we have found a range of mechanisms, and I'll get into describing those shortly, that help countries direct resources towards policy priorities without a legislated earmark. So this work, this whole knowledge product, and some of the results that I'll present to you today, focus on a database that sort of looks at the global experience with earmarking. It then has a few case studies that go into how countries have applied earmarks, and through those we've found some additional cases where countries used things other than earmarks to get the health budget increased, or specific program budgets. And so we have this new taxonomy. So I'm going to get into the results, but first I just want to show you this framework. So in looking at the case studies and taking apart sort of what we learned from the database, we tried to assess all of the different country experience using this framework. Number one, the fiscal context. So what's the fiscal situation in each country? What are the fiscal rules in each country? Is earmarking something that's allowed or commonly used or well used at the country level? Policy design and adoption, and this includes, I guess, three major components. So one is looking at political economy, because we have heard a lot, I think, over the years about how important political economy is for earmarking and also health tax reform passage. Policy design, from two perspectives. One is, what is the objective that you're trying to direct resources towards? Like, what's your policy goal? And then the second is, what is the structure of the earmark, and how have you structured it to meet those objectives? And then the cycle you see in the middle is the PFM cycle. And so we talk about revenue collection, budget formulation, revenue collection, execution of the budget, and monitoring and accountability as major components that are really important to look at the country level, because in some of the experience that we saw with earmarking, there were different barriers or bottlenecks that existed throughout this cycle to getting the revenue to the expenditure purpose. And then we also looked at impact. We looked at impact both in terms of the primary policy objective, and did the revenue help to achieve the policy objective that was initially set out at the policy design and adoption phase. And then any other secondary impacts. So there's a number of secondary impacts that kind of emerged as well. So I'm just going to quickly give you, when I talked about the expenditure purpose and how the earmark is structured. So I think when we're talking about earmarking or any sort of revenue use policy, the important thing to start with is, what do we want to achieve? And so we have this taxonomy that we've developed about defining the policy priority or expenditure purpose as sort of the first critical step, because what we also noted in some countries was that existing channels already could have been used to channel resources towards priorities where there was something in place. So we didn't really need to create a new earmark necessarily to like move those resources to that policy priority. A different channel could have been used. So that's why this is an important step, and it's also important for a number of other reasons. But what we found was that the level at which the earmark is established is important. So it can be a broad expenditure priority like health sector. It can be a program that you're giving the resources to, so a broader program around like safe drinking water or stopping smoking or something like this. And then a population, so targeting a particular group, so like tobacco farmers, youth, etc. And these are then broken down into three sort of types again. So it's this like 2x2 matrix. So compensatory policy, which is meant to offset the impacts of having some sort of a tax in place. Reinforcing policies, which are meant to complement the initial objectives of the tax, and then other social priorities. We know earmarks or revenue from health taxes don't always go to the health sector. There are other sectors as well that receive those funds. And so now this is the set of mechanisms that we have identified. So we know about hard earmarks and soft earmarks. We've heard through a lot of different publications and research over the years. Soft earmarks that align with standard budget practices are preferred to hard earmarks that are more rigid, that don't align to standard budget. And these are the two in red, the two new mechanisms that we've identified, which are these direct commitments and complementary commitments. So again, hard and soft earmarks. Hard earmarks don't align with the budget process. Soft earmarks do align with the budget process. But they're both legislated. And I think that's what's important to note. Like a hard earmark and a soft earmark within the tax law, you will see a legislated link to the revenue going to a particular expenditure purpose. In a soft earmark, there may also be some additional legislation that specifies that the earmark will follow the budget process, and that'll be specified in the budget law. In direct and complementary commitments, there are no links within the excise tax law to that revenue being directed towards a particular priority. It could be sector, program, population, any of the options that I showed you before. But it rather, there's a complementary commitment or a direct commitment that is made at the time of a health tax reform that a proportion of the revenue or something like this will go towards a particular objective. And these have been successful. We have a couple of cases that we delve into in the research, and I'll point to a couple of them as I go through the results now. But in a direct commitment, there is one of those existing channels that's being used. So we have a great example with the program budget that was used to track expenditure flows, or resource flows, and then expenditure, and complementary commitments, which are just kind of standalone policies that are adopted at the same time, but there's not really a discrete channel that's being used to transfer the resources. So I know that's a lot, but now I'm going to go to the findings, so it might be a little easier to digest. So preliminary findings, we find that there's around 70 countries that use health tax earmarks. And again, this is earmarks. It's not these other sort of revenue use mechanisms that we uncovered. And you'll see, I know the numbers might be a little confusing because we see 70 countries and then we have 70 tobacco, et cetera, but many of these countries earmark more than one source. So that's why there's sort of more numbers in the column in the center than the total number of countries. And so there's very broad practice. Tobacco is the most commonly earmarked revenue source, and followed by alcohol and then SSBs. And just to note, linking it back to one of my earlier slides, this is, I think, follows what we understand intuitively now as a result of the research that's been done on the revenue potential of alcohol and tobacco taxes. It really is consistent that these would be more commonly earmarked because their revenue potential is much higher. So this is more of a regional breakdown. So Africa, Middle East, and North Africa, Latin America, East Asia Pacific, South Asia, and then we have Europe and North America here. And you can see by product how these earmarks sort of break out. And then the instrument that's used. So we know from a tax design perspective that designing health taxes as excise taxes is the right way really to go from a best practice perspective. But in terms of the earmarks, they're often structured differently. So sometimes they're structured as a percent of the existing excise, and we go into detail in terms of sometimes it's all of the excise, sometimes it's a small portion of the excise, and that has different implications, I think, in terms of how ministries of finance think and about an earmark, the amount of revenue that will go to an expenditure priority. And then some are structured as additional taxes. So you have the excise, then you have like a 2% additional tax on top of that that's collected at the same time. And then you have others. So there's like other fees or other structures that have been used. And then what is being earmarked for? So we see, I've broken it down in a simple way here, but you can see the sectors, so non-health and health as priorities. The top priority is tobacco control, that at the program level. So most resources went to the program level, not to a particular population and not to the sector overall, but to a program. Tobacco control is the most common, health promotion, NCD prevention broadly. But you'll see in LAC, in Latin America and the Caribbean, that the health insurance was the most commonly targeted program priority. I'm going to go at a very high level through some of the results from case studies. There was 8 full case studies and a couple of rapid reviews that we did. We also did one on Seychelles, but it yielded that despite hearing that there was an earmark, there was not an earmark, and there was some difference in the way that the budget was structured that accounted for this. So many countries, when they went through this health tax reform process, were in fiscal context at the time of the reform. While some countries may have been able to earmark, they chose not to for a number of different political economy reasons. And efficiency reasons. And we saw that in a number of these countries, and we've seen this in other research that's already been published, but the earmark didn't always protect the resources from political interference, from any shifting in the budget. So there was not always that sort of protection. And we also heard, to iterate, I guess, on the points that Miriam made as well, the design is important. And we saw revenue sort of decline to some of these expenditure priorities where the health taxes were not designed well. So that's an important thing to consider. And then I'll just go at a high level through these results. But we went through each of the different phases that I showed you before in that cycle. Most of the earmarks aligned with existing budget formulation processes, the program budget example. So this is actually an example from the state of Philadelphia where the program budget is used to track the resources. It was a very effective and efficient way for them to track the resources, and it didn't have any impact by not using an earmark. There was no decline in revenue over time. It's still, the accountability existed through a different channel. So you can use a different channel to generate that accountability. Collection channels, there was no additional agency or entity that was prescribed in any case to us to collect the revenue, but having a very complicated tax design sometimes limited the ability to collect. And execution, like we were talking about, having a clear idea of what the fund will be used for is very important. Using some of these other mechanisms in some emergency cases allowed funds to be reallocated. But there was some examples where it seemed like maybe what I've been saying, program level priorities are a good way to go. But we also saw some issues with rigidities established through program level priorities. And then monitoring and accountability was really important for being able to determine impact. But we saw some issues with the ability to monitor funds and then needing this strong and transparent reporting to be able to facilitate buy-in. And then in terms of impact, because a lot of the monitoring channels were weak, it was hard to assess whether there was an impact. Obviously, there are some very good examples where we know that there's been an impact on expansion and coverage and things like this, but those sort of need to be tempered with the secondary impacts in some cases. For instance, in one case in Jamaica, where the revenue from health taxes is used to fund their insurance scheme, there was some issues with the revenue declining over time and social insurance contributions needing to come in to sort of fill the gap. So concluding, countries really do need, and I think this can happen with the Ministry of Health, Ministry of Finance, anyone who's engaged in the health tax debate, voices for this to ensure that we have well-designed and well-implemented health taxes. You're not going to get any revenue either for the general budget or for the specific program priority if you don't have that. There are other options other than earmarking, and I hope that through this work we're going to be able to expand the lexicon, because I think earmarking is still a hot button term for a lot of ministries of finance. And then, yes, the policy objectives can be realized very well, I think, in countries who don't use earmarking. It's really important to consider your current fiscal context. If earmarking is something that you've used in the past, if it's been used successfully, and whether you have the capacities to manage it, because it can backfire. And another revenue use mechanism that I discussed today might be a better option for meeting your expenditure purpose. So I just will conclude there. I have a number of references and some other resources, and this will be shared, I think, with you all later. Thank you very much.
Thank you, Danielle. And as you can see, the Caribbean Public Health Law Forum has a very committed steering committee who chose the presenters, who chose the topics. And as you can see, the level of depth and expertise that shown, thank you for helping us expand our understanding and also bringing that new vocabulary to earmarking and other alternatives. I think is an excellent it builds very well upon the previous presentations. But let's move. We have two final presentations, and the next presentation also will bring a different angle to today's session, which also lands some of the concepts that have been presented, and the perspective is of on healthy food. So we have Dr. Antonio Aline, who is a lecturer in economics, the Department of Economics of the University of West Indies in Cave Hill. And his presentation will focus on balancing the considerations and making healthy foods more accessible. Thank you very much, Dr. Aline. Please take it away.
Hi, good morning to all, or good afternoon, I should say. First, let me verify that everyone can see my screen. My
Yes.
intent,
Yes.
thank you very much. My intent today really is to bring a new spin on things, or to add some other considerations before we talk about healthy foods and getting persons to really, utilize healthy food over unhealthy food, making our lives much better. Now, a lot of information was given earlier, so I'll try to not to give you too much detail on the explanations of stuff which was done before, but I'll just give you some general statistics, and I'll go into some conversational type points that I want to bring forth for persons to consider when considering developing policies for healthy foods and such like. Let me see here. Almost not working. Okay, great. Now here are some key points I want to bring forth before I actually start my presentation. And as you can see, the Caribbean, based on the discussion earlier, the Caribbean faces dual burdens, whereas we look at the unhealthy nature or the unhealthy nutrition that is consumed, as well as the level of obesity that exists as on other non-communicable diseases that exist amongst the Caribbean. Now, I brought forward some statistics. We have 10 to 15% of children have undeveloped growth, are underdeveloped, and put it that way. And key areas are in countries like Haiti and Guyana. Then we have the obesity concerns in countries like Bahamas and Jamaica. It was pointed out by the PAHO that non-communicable disease cause about 80% of deaths in the region, or I think it was for 83 was on the slide, I think it mentioned. Non-communicable diseases not only have health consequences, they are also associated with economic, social, and individual impacts. So if you look at from a community perspective or even a national perspective, we can see that countries with high non-communicable diseases tend to have slower GDP growth potential. It tends to reduce the GDP, and because persons are less productive as a result of their illnesses or these diseases that exist. Now, the Caribbean Public Health Agency back in 2016 noted that NCDs not only are mostly preventable, but there can be cost-effective and evidence-based, which we saw earlier, some of the indicators that mentioned by Miriam and the first presenter, that it can be prevented, and in such cases, reduce the death rate and therefore increase productivity as well. Now, there's an article that was mentioned to me that was done in Jamaica's case study that was done in Jamaica. I don't have the reference right now, but the case study basically indicates that for every dollar spent, we can on reducing or investing in the reduction of non-communicable diseases tends to lead to double that, or say $2 or over $2 worth in GDP growth. So your GDP or the country's wealth will increase by a factor of 1 to 2 or thereabout over any investment within into preventing non-communicable diseases. Now, I have here some dietary trends which I want to point out too as well. So when you look at the current trends in the region, processed foods account for about 60% of dietary energies in Europe, in the urban Caribbean, and this is a study done by FAO in 2022. Sugar, sweetened beverages consumption, highest in Jamaica and Barbados, which is not listed here, it was quite high as well. By the International Diabetes Federation, I think that's the pronunciation, it was considered there. So these institutions have basically indicated the level of concern that we should know, because it's not no longer just bad habits, it has become now a lifestyle trend. So if you look at this high consumption of processed foods, these SSBs, and low intake of what we call healthy produce, vegetables, fruits, water, tends to lead to other a number of NCDs, which includes diabetes, hypertension, obesity, and the list goes on. Again, but to alter this, it tends to require making healthy foods more affordable. And I listened to a number of the presenters before in terms of how to go about doing this in terms of taxations and so on, but there's a number of other elements I think should be considered when we are dealing with these things, when addressing, because they're economic as well as cultural factors that also needs to be considered, right? So some of the key barriers indicate would be cost. Obviously, healthy food is often more more expensive due to higher taxes. We've seen that in the case study of Barbados, and I will not go into the case study of Barbados, just mention one or two things because it was clearly demonstrated by Miriam too as well in the earlier presentation. But what I want to do is basically highlight how the fact that there's notable evidence that healthy foods are tentatively more expensive than the processed alternatives. And then there's the availability. In our countries across the Caribbean, a lot of Caribbean countries are small, so there's limited produce available, and that is as a result of cost factors, that's a result of a space factor, there's a number of other reasons why we're doing it, and then the level of income earned, persons are seeing it earning income in other sources much better. And then there has been a cultural shift. So the cultural preferences, as I said before, has shifted towards faster, what we call fast food, or we call quick food, which is all those processed foods have also lead to bad health and so on. And in Barbados, in Trinidad, 25% of sales of fast food grew in sales between 2015 and 2022. That is a remarkable figure if we think about it. So moving on to what I really want to get into, talking about some of the essence and other considerations, we look at policy and economics. Now, we talk a lot about trade policy and how we should implement these things, but when developing trade policy, policymakers need to also consider that many Caribbean countries themselves rely heavily on imports. So our consumption pattern is based on imported foods, and a lot of these are processed foods, or what we call the cheaper alternative. Locally, the agricultural sector tends to struggle to compete with international or even sub-regional partners because, again, for the lack of size and so on. So this reduces the availability of fresh produce produced locally. And obviously, price is a key factor as well as space, as I mentioned earlier. So these are some of the key factors that we should look at. Now, taxation, which was discussed heavily, I want to point out that well, I should ask the question, should unhealthy food be taxed? And by how much should this be taxed? In other words, is it that is there an infinite limit, or is there a limit to it? Because why I ask that question is because a number of these institutions, or let's just say enterprises, who produce the unhealthy foods are the more influential within the region. So I'm not going to call any names, but are some of those sweet and sweet beverage producers tend to be these institutions or these enterprises are major contributors to other aspects of the economy. So these are things that we need to consider as well. And then how much should healthy foods be subsidized? That's the next question, because based on the information that came out from the studies on the Barbados's sugar-sweetened beverage policy, I can tell you that a number of recommendations was to subsidize local farmers, local producers, and so on. But again, by how much should we subsidize? Because we need to make the local producers competitive, yes, but at the end of the day, they also need to be able to make it the product affordable, right, for the average person. So again, we're battling two fronts here, whereas how much do we need to subsidize the local producers, as well as how much can we tax the international or the multinational corporations, we put it that way, who contribute to the unhealthy food system. All right, this is the Barbados case, but just let me point out that it started out at 10% in 2015, but it has increased in 2024 to 20%. Now, there haven't been enough evidence to show whether or not there's been a drastically decline as such, but based on the 4% decline that we've seen from 10% in a study done here at the University of the West Indies, we expect that we should double that by 2030 according to the PAHO's own research. Based on that information, we would assume that we see a decline, but is 4% and 8% really significant enough to really dent bad practices that we have in the region already? So that's the question. So again, strong policies are needed, and we need policies to not only just tax, but we need policies to educate the public, and other complementary measures like promoting the intake of water. Now, there was a mention of taxing bottled water, which is, you're taxing water, which is supposed to be the healthiest. Is there anything that should be cheaper than water? No, in my opinion, but we still tax the suppliers of water, of bottled water. Again, is that really cost effective, or does it really help with the initiative? Now, strategies to improve access to the healthy foods. Now, these are some of the strategies that I would like to promote in terms of supporting local agriculture. Yes, farm to school programs subsidizing local farmers are key initiatives. This is one that you can take in terms of Jamaica's case. This Eat What You Grow initiative that was a study that was in 2023 showed that 40% increased school garden participation by 40%, which means schools are now getting more involved in that case. If you look in Trinidad, 5-a-day campaign raised fruits and vegetable intake by 12%. In Mexico, junk food tax reduced. Now, as you can see, there are multiple. We have to tackle it from multiple facets as we go forward. Reduced purchases by 7%. Now, as you can see here, good practices over taxation leads to greater returns thus far. Right, and if you look in terms of Jamaica, again, Kingston's farming market increased fresh fruit access for 50,000 residents. Now, again, we talk a lot about taxation, but again, taxation, and I'm not saying that it is not warranted. It definitely is. However, it leads to the smallest benefit that we've seen so far in the Caribbean. Now, a lot of these practices need to replicate it. I'm not going to say that they will be just as effective or even less or more effective, but these are good practices that can move forward across the region. The entire region should utilize some of these practices, learn from each other going forward. So we supporting local agriculture, promoting nutrition in the school system or educational system, imposing well investigated pricing structures. Now, again, that's to do with taxation, and include the urban communities in the planning process. So if we get those communities well involved and see where benefits do lie, not only from a financial but from a social or health perspective, then it is more likely that more farmers and more farmers markets, in this case, would evolve and therefore restrict that intake of fast food in schools and to the youth and so on. So that's where we need to start. We need to start with at the youth level. Challenges and trade-offs. Now, there are a number of challenges that we will face and we will continue to face, and this is what the real consideration needs to be placed on. So if you look at the fast food and beverage companies, the tobacco and such like, may resist taxation given obviously their size and the influence that these enterprises hold. So that is one, definitely, and I pointed out 1 or 2 studies that were done or reports that were done in relation to different countries and so on. So subsidizing vegetables and so on. So obviously you make it more affordable and more, and so is it affordability versus health, or is it for the affordability that complements increased health? So that's the question we need to know what we're trying to do. So we subsidize vegetables in St. Lucia, cut costs by 20%, but uptake was low. As you can see, price has one aspect, but then is the educational side that needs to go along with it. So as I said before, nothing should be cheaper than water, but we still tax water. Why? I really don't get it. Cultural shift. There's a deep-rooted dietary change or habits now that taking place. In my younger years, going to places like KFC and I'm not saying that let me just not calling it. Going to these fast food restaurants was once it was like a treat, but now we given our development status, we've reached a level where as everything comes, we want everything fast. So we get fast food. We're not considering the implications as a result of this. And but that culture, that shift, we need to reverse that trend now. So and it will take some time. However, the question again is and the severity of how we attack this would require us to answer the question: how can we generally wait for a generational shift, a reversal, or should we now force this issue moving forward? I have some regional initiatives here listed. It would have been Guyana's, obviously, school garden initiative, and then you have Barbados Suite. So I'm not going to go into these, but as you can see, the studies are here outlined, and we can actually speak to a number of these different things. Like I said, a lot of them were delved into by the previous presenters. So what I'll do is just skip those, but you can note that these are sources where you can get information about these particular products. Right. And call to action. Someone mentioned a call to action earlier. So this is my call to action for governments, communities, and individuals themselves need to play a role in how we move forward. So government obviously have to implement smart food policies. So we talk about taxation, incentives, quotas, whatever is necessary, to impose these things will be required, may be required. We need to also invest in local food production. This includes having discussions with those unhealthy enterprises and see where they can add value in this realm, not just because they're producing and we can't, and we don't want to, rock the boat. We can say, okay, well, you don't want to rock the boat, but find better ways to play the money's gain and see if you can meet us halfway, something of that sort. For communities, obviously we have to advocate for better food access. Amongst ourselves, we need to, promote these kinds of things. And then support the educational efforts being made by government and by the individual communities themselves. Highlight these benefits, these positives. And for individuals, obviously, we need to make smarter choices. The information is there. We need to educate. And if you're not educated, seek education, or in a case whereas take the government has been promoting a number of these things in all forms of media, paper, radio, TV, everything. I've seen it here in Barbados and I've seen it in Jamaica. And you can see that a lot of this is being promoted across the region. Now we have to, within ourselves, make that choice to do better or to take, because at the end of the day, healthy food accessibility requires policy, education. It requires a full economic balance. If you think about it, it's a full economic balance. Now, Barbados is, and I'm speaking for Barbados and the other countries. Now, these are steps in the right direction, but clearly we need more, right? As you can see, the initiatives in Jamaica, in Guyana, and Trinidad, and so on, they all add value, right? So, as I asked before, is that projected 8% from a 20% tax on healthy foods enough? So I'll end there, and hopefully you can have some vibrant discussions later on. So I skipped most of the areas where persons would have gone over in terms of any details. So that's where my points here.
Thank you. Thank you so much, Dr. Aline. And you broadened the scope. I think this is really, we hope is an intriguing conversation, and the topics you added another layer, really looking towards that building coherence among policies that go from many different areas, from economics to a food systems approach. Please indulge us with a few more minutes. Thank you all for staying with us. And we were ambitious in this webinar, but we have a wonderful presenter, Rachel Morrison, who's the Senior Advisor for the Caribbean at the Global Health Advocacy Incubator, a very important civil society organization, and she's presenting on the role of civil society in the promotion of SSB taxes as an instrument of public health policies. And we appreciate you, Rachel, for staying with us, and please take it away. Your audio may not be on, Rachel. We can see your PowerPoint.
First. Okay. Can you hear? Can you hear me now, Gloria?
Yes.
Sorry about
Yes.
that.
Yes.
Hello, everyone. I will try and be as brief as possible, just to ensure that we get through and that there's time for some discussion. So, can everyone see my slides? No?
Yes. Yes.
Okay. So, sorry, everyone but me can see them. Okay.
Yeah,
Okay, here we are.
it
Yes.
just went
Okay.
away.
So as
Uh,
Gloria mentioned,
Rachel, the presentation went away.
okay, sorry.
Let me
See if
see.
because 1 second. Let me just share screen again very quickly. Can we see my screen now?
No,
Okay.
do you have to?
Okay. Actually, here. Yes. Yes.
Okay. Yes, and if you can come closer to the mic a little bit.
Sure, no
Okay,
problem.
perfect. Thank you so much.
Okay. Yeah, so as I was saying before, I mean, nothing is done in sort of a vacuum, you know. We recognize the importance of the role of CSOs as we work very closely with them on our food and nutrition program at the Global Health Advocacy Incubator. So for us, CSOs, you know, play a very vital role, and we've been engaging with them directly to really work on legislative and policy reforms that can impact public health policies across the region. And so some of the things that we've kind of looked at in terms of the significance of working with CSOs and the important role that they play, you know, start by really their ability to convene different stakeholders and bring different groups and individuals together, like lawyers. So really creating sort of a powerful coalition to support policy development. And this photo is actually from previous work done by our CSO partners in the region. And really, you could see like the multi-sector stakeholder approach. They collaborate with development partners like PAHO, other regional entities like the OASIS, and really pulling together really strong voices across the region, which is very important when you're trying to convince people about the importance of the policy that you're working on. Another very important thing is unless you have been under a rock in the region, you would at some point have been engaged by, you know, some really strong public communications. And SSB taxes is one of the big areas that our partners have been working on in terms of making sure that there is a good understanding of the importance of SSB taxes, speaking about the impact that it can have on public health, and trying to ensure that that message gets widely disseminated to the public so that you can have strong public support for SSB tax advocacy. Another very important thing that CSOs can do and have done in supporting public health policies, and in particular SSB taxes, is really trying to not only generate evidence, but also disseminate and simplify evidence. You know, a lot of what the public has to come to grips with to understand sometimes, you know, especially us as public health advocates, we're in the field and it's, you know, it's all in our head, and, you know, it's for us, it's very clear, but it's not as clear for the public. And so CSOs have been very good at taking some of the strong research by persons like, for example, Miriam was on the call earlier. So some of research that would have been done by Miriam, her partners at Georgia Lane, you know, other researchers, and packaging it in a way that's very simple and easy to understand, right? And if you've ever worked with policymakers, you understand that, you know, or you've ever had to engage policymakers, it's really quick, it's really fast. And so when you're sharing information, you really want to share research and evidence in a very simplified, easy to understand way. And another good thing about CSOs and this network that they've kind of built out, even in working with us and there's opportunities to cross collaborate with other CSO partners and really get a chance to build on the evidence. So we've been able in particular to really facilitate a lot of the CSOs we work with in having discussions with each other, sharing evidence and research from their specific context. And that has really strengthened the level of advocacy that each CSO has been able to conduct in their local environments and contexts. Another important role that CSOs play is really in countering a lot of the misleading claims by private sector interests that are seeking to disrupt health policy. Now, I know we like to think that the world is a wonderful place and that nobody is there to do any harm to anyone, but unfortunately, that's not really how it works. Everybody has their particular interests. And so a lot of times, even as we try to advocate for fiscal policies and we share all the evidence in the world, you find that you come up against a lot of opposition and a lot of opposition that is not based in truth. You know, one of the biggest things in relation to SSB taxes that we've come across is this very misleading idea that somehow taxes are going to, if you put in SSB taxes, then persons are going to lose jobs. You know, and that absolutely has never happened in any context where SSB taxes have been put in place. And so, you know, CSOs play a very critical role in trying to balance and make sure that that evidence gets out there and that, you know, anything that is misleading is sort of dispelled. Another really important thing that we've been able to take a lot of advantage of over the last couple of years is how CSOs have been able to create opportunities for young people to be expressive and to share how these public health policies can impact their health needs, you know. So it's been a very, very critical form of advocacy that CSOs have been able to tap into the voice of young people and really kind of helping to have them be the ones to share their experiences in terms of how unhealthy products have been marketed to them, their exposure to unhealthy products at an early age and the impact that it has had. And, you know, really kind of understand that, you know, they're looking to policymakers to put policies in place, yes, and even fiscal policies that can help them to make better choices, you know. So that has been a very, very strong voice that CSOs have been able to tap into and create and support advocacy opportunities on policies. So another big thing that our CSO partners have worked on is, of course, you know, just trying to support healthy taxes, trying to reduce, increase access to healthier items, as Antonio would have discussed and mentioned. And, you know, also trying to kind of have a bit more balance in terms of the food environment and making sure that unhealthy products are also taxed. And I think there is a level of consistent advocacy that needs to occur when you're trying to promote fiscal policies, right? And healthy taxes, right? Because as I mentioned before, there is a lot of noise around policymakers, right? And so you need to consistently be providing this message of the positive impact that health taxes can have. And so even with the recent announcement in Barbados, right? I'm bringing your attention to this post just to note that, you know, it's a continuous process, because even though right now, as you know, we've heard it's at 20%, but you know, we can get greater benefit from it in increasing the SSB taxes. And so there's this consistent messaging and continuous messaging that has to come from CSOs to make sure that the issue stays relevant and stays prioritized, right? And it is a very strategic action to congratulate the government whenever they put in these taxes, because remember now, as they've put in these taxes, in the public space, they're going to be confronted by industry. Even if you don't see it happening overtly, it's going to happen in covert spaces. So when CSOs continue to support governments when they put in specific taxes and measures, you know, and congratulate them, that's part of the overarching strategy to continue to push for increases, to continue to keep the issue of health taxes on the agenda. And then another, and this is my I think this is my penultimate slide. Another really big thing that we have worked with CSOs on is actually defending public health policies. So we have had partners across the Latin America region who have come up with it, who have faced opposition to taxes that they would have supported implementation around. In most recent times, we've had specific issues in Argentina and Colombia, who have all put in some form of unhealthy product taxation as part of an overarching health policy framework. And so it's our CSO partners who have been the ones at the fore trying to support the defense of these public health policies with their legal teams, with their legal partners, you know, really trying to mount a very, very strong, and also with using things like strategic litigation where communications is also strong, but really trying to ensure that, you know, the policies, fiscal policies and measures that have been put in place are not sort of broken down by industry because they've decided to take the governments to court over them, right? And that has been very, very helpful. And there's a lot of good evidence and case evidence out there in terms of the value of tax policies. So this is definitely something that CSOs have been very, very helpful in terms of supporting. And so to end, just to say that, you know, CSO, civil society in general, continues to play an essential role in creating and sustaining critical health policy, right? And I think one of the things that we need to always remember is that, you know, civil society represents the persons that are most affected by these policies. So it is absolutely critical that they're able to kind of represent this constituency and ensure that strong policies are put in place for their protections. Thanks.
Thank you so much, Rachel. Thank you also for bringing us to kind of this, bringing this other perspective as well from civil society. So today we've been able to bring from so many different areas of knowledge, from economics, from nutrition, from policy design, and bringing it all different academic fields and ending with the civil society perspective. So we thank you. We recognize we've gone over time, but possibly just in fairness, yes, we have HCR with us, and I think a few of the other panelists as our webinar has extended a little bit more. And yes, HCR, if you like to please go ahead and provide your perspective. We will only be able to take possibly one question, as I was recommended to place it on the Q&A. So let's, in all fairness, give that, and we'll be happy. We are here, the Caribbean Public Health Law Forum. I'll put some resources on the chat, and send us also recommendations for further programs, as well as, again, this is just part of that continuity of conversations today, specifically on this topic. Yes, Itziar, if you'd like to take the question that was placed on the Q&A.
Sure. So the question is mostly about sugar-sweetened beverage taxes, I understand, and their impact on consumption and NCDs. So what we do see at evidence at a regional and global level is that if effective structured taxes do have an impact on consumption. We see this consistently across the board. As Miriam mentioned, the design makes a lot of difference, so we have to make sure that these are sufficiently high. But overall, globally and regionally, we do see that there is an impact on consumption. As these taxes are implemented or increased, we do see a decrease in the consumption. In terms of the impact on health, it's important to consider the lag. If you implement a tax today, you're not going to see an impact on NCDs tomorrow. There's a time lag in between when the policy is implemented and when you can realistically expect to see health results. During this time, it's important to not just implement a policy and let it be. It's important to continuously decrease the affordability and continuously improve the policy design. For example, in Mexico, we do see that the policy was successful in decreasing consumption, and especially in the most vulnerable populations. However, we see that it has only been indexed for inflation, so it hasn't been consistent in continuously decreasing the affordability. So that's a key element, because we want to continuously decrease affordability to continue decreasing consumption. But in terms of the health impacts, it's going to take a few years. You're not going to see these results in NCDs over a short term. You can see results in the decreased prevalence of caries. For example, in children, we do have some examples of that, and we do start to see decreases in body mass index in some evaluations in municipalities in the United States. So I just do want to set expectations in terms of sugar sweetened beverage taxes. There's a lag, but we're starting to see the positive results. Miriam, I'm sure you have some things to add.
Sure, thank you, Itziar. Thank you for highlighting those important kind of structural components to the timeline on which we might expect to see results. One thing I wanted to add is that from kind of a similar magnitude of SSB tax in the UK, the soft drinks industry levy, which was implemented in 2018, they've been able to observe reductions in hospital admissions for dental caries, like for extracting teeth that in an emergency scenario, and also for childhood hospital admissions for asthma. So these are two NCDs which have the least amount of time lag, and so we're starting to see empirical evidence of those improvements following a similar type or similar magnitude of SSB tax. So I think that's also really encouraging in terms of the timeline for seeing some of the longer lags. We might need to look a little bit further out, but it seems like the earlier and more acute NCDs really are manifesting those changes as expected. I'll try to add links to those in the chat. I was having an issue with it earlier, but keep an eye there and I'll try to link to those papers.
Thank you. We also added a few, and just to bring us to a close, if Dr. Aline or Rachel have any final comments, please let us know. Or yes, please.
Just a general comment. When we look at this problem, is clearly more complex than we think. It's not a case of just adding numbers and dividing and coming up with ideas of tax policies and so on. There is a wider factor that we need to consider all the time that we tend to push aside. We figure, well, taxes and subsidies will do the trick. There are multiple approaches to doing so, and we will obviously investigate and find the most avid approach to getting a solution. But again, we need to have greater discussions with both locals as well as those institutions and those enterprises that actually have an impact on the society as well. So that's my 2 cents.
Thank you, Rachel.
And I'll be 30 seconds just to say that I think it's very important for us to recognize the role that different stakeholders can play in supporting health tax policy advocacy, right? What you find is critical towards kind of maintaining and sustaining health tax policies is just having a consistent range of different voices, a range of different expertise. And so, if it's one thing I would say, feel free to lend those expertise to different CSOs working on these policies in the region, because, it will help. Every voice matters.
Thank you so much. And I want to again thank this very distinguished panel. Your contributions, your presentations were amazing, and it really merits dedicating much more time. We are very thankful. And I also want to bring us to a close by saying we have an NCD crisis. We have an NCD epidemic, truly. Therefore, yes, there won't be one solution, but health taxes are part of that portfolio of solutions towards this major problem that, as it was discussed, will eventually affect our development, our economies, and our overall well-being. Therefore, we're exploring all the different types of policies that can bring us closer to a healthier Caribbean. So thank you again for participating, for staying with us. We will be sending you the recordings as well as the presentations. And please feel free also to share the recording and make these messages available. Thank you and take care. Have a wonderful afternoon. Bye-bye.